Mental Health, Chapter 31, Schizophrenia and Other Psychoses. I'm going to skip right through the objectives, and I'm on slide 4. So psychosis, what it is it's the inability to recognize reality, the inability to relate to others, and the inability to cope with life's demands. The most common psychosis is schizophrenia, which schizophrenia is actually a related group of disorders that are characterized by disordered thinking, disordered perceptions, and behaviors. These are diagnoses where the patient's or the client's reality is distorted and disturbed. The most common psychosis, as I said before, is schizophrenia, and this is a group of related disorders. Now, other psychotic disorders could be a brief psychotic disorder, and this is a period of psychosis that lasts more than a day, but less than a month. And a lot of times it can be stress-induced. There's delusional disorder. And a delusional disorder lasts for more than a month, and it's what they consider to be reality-based fixed ideas. For instance, someone is convinced they're being followed. So, I mean, it could be a reality, but it becomes almost like it's an obsession. There are psychoses that can be related to medical conditions or drug use. We see this in the elderly sometimes. And there is the schizoaffective disorder, where there is, on top of the psychosis, there's depression or mania. Now, neurobiological functions, what this really means is the ability to function, change, and adapt is influenced by physical brain functions. Okay, so we're saying that the ability to express your behavior is influenced by physical functions of the body. And if you were to take like a long timeline or a continuum of behavioral responses, on one end you would have the highly adaptive and the highly effective responses, and on the other end you would have the maladaptive or destructive behaviors. And this goes from all the way, if you picture a timeline, again, like I just said, one end is the maladaptive responses, the other end is the adaptive responses. And individuals who do not adapt as well as other people are placed in the middle of this spectrum. The maladaptive person would be someone who has thought disorders or delusions, hallucinations, inability to experience emotions, thinking is disorganized, behaviors disorganized, social isolation. And on the healthy or adaptive end of this, we see people who have logical thought responses, accurate perceptions. Their emotions are consistent with what's going on. They have appropriate behavior. They have social relatedness. They have friends. They have family members, people they're able to associate and relate to. And these patients can also adapt to the environment. So psychosis in childhood. Well, failure to thrive syndrome in infants is a slowed physical growth caused by the inability to integrate the physical, emotional, and sensory motor realms of functioning. So this child is not processing their environment. Normally, by 2 years old, these clients will start to integrate these realms. And then a healthy child, by the time they're 4, they have a rich and complex fantasy life. And in the school years, children start to show their intellectual side more. Psychosis in childhood can be related to neglect, environmental problems, and severe family stress. And this would be a child who, didn't have an opportunity to experience healthy activities, didn't have a chance for normal growth and development. Now, risk factors for childhood schizophrenia: genetic influences, complications during pregnancy and birth. For instance, sometimes we're finding a little bit more moms that were exposed to the influenza virus or had very complicated labor and delivery. We're finding a correlation between that and a schizophrenic child. And then there's biochemical imbalances, neurotransmitter disturbances like dopamine. This child would perceive things and act differently. We have found that psychotic disorders can be seen and can occur in children as young as 5 years old, just 5. Okay? Children that are heading this way can have impaired ability to process visual information. They have trouble regulating their attention span. They have trouble sorting out incoming information. They have affect changes. Language and communication problems occur, and they can actually have motor and emotional control issues. They have trouble thinking logically and communicating effectively. They sort of enter a world of their own. Now in adolescence, so the average teen is in contact with reality, whereas a teen with schizophrenia is not. And there are changes in behavior we see in teenagers who develop schizophrenia even before a full-blown psychosis occurs. Things that we see are poor hygiene, strange, vague speech, social withdrawal, odd behaviors, for example, hoarding food or talking to themselves immensely, bizarre thoughts and beliefs, unusual superstitions, self-injury, destructive behavior, and telepathy, honestly believing they can read someone else's mind. Now, psychosis is in adulthood. So the onset of acute psychotic symptoms most often occur in men during their middle 20s, whereas women, it's usually a little bit later in their 20s that the symptoms show up. Now, with continued treatment, about a third of patients diagnosed with this will improve. Without treatment, a third improve and a third progress into a chronic downhill course. Women who are having psychotic episodes will normally seek help before men, but men have higher relapse rates. Many times patients are sent home from hospitals or institutions too early while they are still having psychotic events. And then they require supportive care, etc. at home. And this becomes tough on the caregivers and with a frequent relapse rate. The average stay in a mental health institution is 10 days. The prognosis for individuals with schizophrenia is better if adaptive interpersonal relationships and acceptable school performance and work histories were in place before the onset of symptoms. Now, psychosis is in older adulthood. Schizophrenia is seldom diagnosed in older adults. Older adults with schizophrenia may spend the remainder of their days in long-term care facilities. And remember that the acute onset of psychotic behavior in any elderly client must be investigated. Once diagnosed with schizophrenia, the life expectancy is 12 to 15 years shorter than someone who doesn't have schizophrenia. And a lot of patients with schizophrenia die from cardiovascular disease, suicide, accidental deaths. They die prematurely from natural causes, and they often have a diminished quality of life. Schizophrenia exists in all cultures, and all socioeconomic groups. So theories as to why this happens. Well, there's the biological theories, and these all have to do with brain activities. And there is evidence more and more that schizophrenia is a brain disorder, not a mental health disorder. This is gaining a lot of support as more and more research is done. The genetic heredity model helps explain by studying patients' genes. Now there's the stress, disease, trauma model. And this addresses the effects of stress on a person, especially during a prenatal period. Malnutrition during pregnancy has been linked to schizophrenia, complications during birth, as we said before, illegal drug abuse by the mom. And then there's the neurochemical models. The neurochemical models feel that your neurotransmitters, such as serotonin, norepinephrine, and dopamine, are possible causes of schizophrenia. And these models state that they feel in clients with schizophrenia, their levels of neurotransmitters are altered or imbalanced. Other theories are the psychological models, and these theorists believe that schizophrenia is caused by a basic character flaw combined with poor family relationships. So they think it's a combination of society and environment that actually cause schizophrenia or psychosis. And examples would be like an extremely overprotective mother, or a cold or uncaring parents, no trusty relationships. Sociocultural theories believe the effects of the environment may lead to the development of psychoses. And by that we mean the effects of poverty, homelessness, unstable families, cultural differences. So schizophrenia has many different, well, 5 listed here, different subtypes. Now, 1% of the world's population has schizophrenia. 2.5 million people in the United States have some form, and 10% of them will commit suicide. So, the first type of schizophrenia is catatonic. So this person has motor immobility along with odd voluntary movements. They have rigid posture or assume a posture for a very long time. They may be mute. They may have echolalia, echopraxia, where they mimic the movements of others. They may suffer from malnutrition, dehydration, and exhaustion. Some of them don't eat or drink, and the prognosis for this type of schizophrenic client is fair. Disorganized schizophrenics are unable to think straight. Speech and communication is difficult. The affect is flat or inappropriate. There are unusual mannerisms, distorted facial expressions. This client will giggle or cry out. Loosely organized hallucinations, delusions. This person is withdrawn. They're unable to perform their ADLs. Onset is early and prognosis is poor. Now, the paranoid schizophrenic constantly feels that someone or something is out to get them. They have organized delusions of grandeur, which, is a false impression of one's importance. They have delusions of persecution. They believe they're being persecuted, like harm is actually occurring. They have auditory hallucinations, high anxiety levels. They are suspicious. They are guarded. They can be violent and or suicidal. The onset of this sub-disorder is late, and the prognosis is good, but only with treatment. Now, undifferentiated schizophrenia means the client doesn't meet criteria for the other subtypes, but still has delusions, hallucinations, and disorganized behaviors. The prognosis is fair. And then there's residual. So the residual schizophrenic client has had at least one acute episode of schizophrenia and is free of acute psychosis, but still has withdrawal, emotional changes, and odd behaviors. Schizophrenia has been present for many years. Time becomes limited between acute episodes. This person has a poor prognosis. It is characterized by blunted or inappropriate emotion, social withdrawal, eccentric behavior, loose associations, but they do not have the prominent psychotic symptoms. So, signs and symptoms. Well, the main characteristic of psychotic disorders is loss of contact with reality to the point where functioning is actually grossly impaired. Okay, perception is altered. There's hallucinations, illusions, agnosia. Agnosia is the inability to recognize familiar objects or people. And I think that came up in MedSurg somewhere. Agnosia is the inability to recognize familiar objects or people. Delusions are fixed, false ideas that aren't based on reality. Clients with schizophrenia, signs and symptoms are things that affect perception, physical appearance, cognitive processes, language, speech, emotions, behavior, and social realms. Most of these patients look unkempt. Hygiene is poor. Characteristic symptoms fall into two broad categories, positive and negative. So positive symptoms relate to maladaptive thoughts or behaviors. And this includes hallucinations, speech problems, bizarre behaviors, feel that the media is talking about them. Or there's negative symptoms. And these relate to a lack of adaptive mechanisms. They have a flat affect. They're withdrawn, poor grooming. They have lack of speech. Other things, other language difficulties, echolalia. They have trouble with concrete thinking. They can't think abstractly. Everything is black or white. Okay. Thought alterations. For example, perseveration, which is repeating the same word or idea after the same question. All right. Inability to have new thoughts. Poor judgment. Emotional alterations, a labile affect, difficulty in identifying and describing emotions, apathy, and behavioral alterations. They have no impulse control, lack of energy or motivation, and no coping or maladaptive coping behaviors. And these clients cannot maintain relationships. They have very low self-esteem. So, the phases of becoming disorganized. Well, it begins with withdrawal, lack of energy, not a lot of motivation. Client may appear confused and as if they are in their own world. They show extraordinary interest in religion or philosophy. They may have poor hygiene, odd ideas and beliefs. Speech is difficult to follow, and they can become agitated or angry. Okay? And all of this happens during the prodromal phase. So normally, patients will slide into the role of schizophrenia over 4 stages, and those are the first things that happens with the withdrawal, the lack of energy, appearing confused, patients in their, like looking as if they were in their own world. And next what happens is the pre-psychotic phase. Here the client is quiet, they're passive, they're obedient, but they prefer to be alone. They have no or few friends because of their odd or suspicious behaviors. Delusions may or may not be present. And sometimes families describe this stage as watching the person slip away from them right in front of their eyes. The next is the acute phase, and this is where we have acute disturbances in thought, perception, behavior, and emotion. They lose contact with reality. They are unable to function even in basic ways. Next is lack of energy. They have no interest in goal-directed activities, and this all comes in the residual phase. They have a negative outlook. It's kind of, and some of the same symptoms as the prodromal phase start to show up again. And then there's actually some forms, some schizophrenic patients or clients actually go to some form of remission, where some basic ADLs can be performed again, some relief of psychotic symptoms, but they can also relapse. Now there's other psychoses. There's brief psychotic disorder, which I think we mentioned this before. It lasts longer than 1 day, but less than a month. And we also mentioned delusional, more than 1 month of reality-based or non-bizarre fixed ideas like someone is following you. Okay. The shared psychotic disorder. This is an individual is influenced by someone else who has an established delusion. And schizoaffective disorder. Again, this is where mania or depression is also present. Now, the goals of inpatient short-term care should include the following. Stabilize the client. You want to prevent a further decline in functioning. You want to help them to cope with his or her disorder. And long-term goals include psychosocial as well as vocational rehab, meaning training or career work, helping them find something they can do for work and to support themselves. There's pharmacological therapy. So antipsychotic or neuroleptic drugs are used. And neuroleptic drugs, depress nerve functions in the CNS, okay? And they slow things down. And these are used, as I said, to treat psychotic disorders. And then there's antipsychotic medications. And after an antipsychotic drug is taken, hallucinations and delusions decrease, thought processes change, and hyperactivity subsides. Sometimes we find that withdrawing clients start to socialize. All right, but again, this works in the central nervous system. Therapeutic interventions, well, your nursing diagnosis would include disturbed thought process, disturbed sensory perceptions, social isolation, impaired communications, ineffective management of therapeutic regimen. The basic goals of care are to assist these clients in controlling their symptoms and achieving the highest level of functioning that is possible. Now, in your short-term goals, you're going to keep the client safe. You're going to restore them to adequate nutrition and rest habits, and try to help them maintain a contact with reality. So, special considerations that can come up. Well, a lot of times the antipsychotic medications, they alter the CNS and the peripheral nervous system functions. So these are things we have to think about. There's the extrapyramidal side effects. And these develop because of an imbalance of dopamine and acetylcholine in the brain. 75% of patients who take these antipsychotics end up with some of these side effects. And they can actually get symptoms that make it appear that they would have Parkinson's disease. There can be anticholinergic effects. Patients have had trouble with akathisia. Akathisia is the inability to sit still. All right, so if you can't sit still, you're having some akathisia. Akinesia is the absence of movement. Bradykinesia is slow movement of body parts and a diminished mental state. Dyskinesia. Dyskinesia is involuntary abnormal skeletal or muscle movements. Dystonia means you have impaired muscle strength or muscle tone. And then there's neuroleptic malignant syndrome. And this can be a fatal side effect of some of these medications. It can occur from respiratory or kidney failure on someone who is taking very high potency antipsychotics. Nursing responsibilities, well, nurses need to review the desired action, side effects, and incompatibilities for each medication prescribed. Monitor the client's response to each medication. And remember that client and family education has a huge impact on the client's level of functioning. And that